Thank you. So I'll straight away go to the Doppler of this lady who has undergone mitral valve replacement. If you look at this is an atrial fibrillation. The peak velocities have not gone beyond 15 millimeters of mercury. The mean is 7, and if you average it out, it will be somewhere around 6 or 7. That is how you are supposed to do it for atrial fibrillation. This is the 2D, and if you look at the 2D, what you see is only one leaflet which seems to be moving. Mind you, the Doppler is 6 or 7 for a mitral bileaflet, which is absolutely acceptable range. If you look at this, again, single leaflet, I'm twisting and turning and trying to see it from all the sides. Many a times you will not be able to see. So this is this lady's tricuspid regurgitation, and when we compared it with recent pre-op, we found that the gradients were having a sudden jump. So this is PG of 37, add on to the IVC, which is dilated, which hardly has any respiratory variation. That means the tricuspid regurgitation truthfully is representing a sudden surge in the pulmonary artery hypertension. So we were a little confused, can't see both the leaflets, the patient is not doing too well. We did a T, and here clearly you see that there is one leaflet which is moving and there is one leaflet which is stuck. The dichotomy continues because why is it that the gradients were so low? We did a 3D, conclusively proving that this leaflet is moving reasonably well and this is the one which is stuck. Stuck. Fluoroscopy, and here also you see that this is stuck. Now these are images which are very gross, but this is, you have proven it enough and more number of times that the valve is stuck. Why is it that you have this? I'm going to show you two images side by side now, which will give us an answer why this lady had this problem. This is the one which is normal. If you look at this, you see two leaflets. St. Jude's is bileaflet, they move like a wing. Both of them are saying you see two blobs here on the right. If you see these, they have one blob here, one blob here. And this is a stuck, this is well moving. However, if you go on to the left side, this is the Doppler in question for our lady, only one is seen. And we know she has had a bileaflet. We know she has got a stuck well. Where is the problem? The problem is in the left ventricle. When your left ventricle is poor, your left ventricular end diastolic pressure goes up. When your left ventricular end diastolic pressure goes up, you get a gradient which is much lower than a stuck valve would have. And this is known as a silent Doppler prosthetic valve thrombosis or stuck valve. We didn't have a thrombosis here, it was pledget which kind of was obstructing and stuck. So in conditions of low cardiac output, the transvalvular gradients can be seen with normal range despite significant prosthetic valve obstruction, and this is called as silent Doppler prosthetic valve thrombosis. So it is appropriate that whenever there is a clinical suspicion, or even if your index of suspicion is such that you see only one leaflet moving, the investigation should be completed with a transesophageal study or a fluoroscope. Now, if this is not classically recent post-op, but still I just want to show this case, very interesting. 22 years old girl underwent aortic valve replacement with 17 millimeters of St. Jude's, mitral valve replacement with 27 millimeters of Medtronic, and tricuspid valve replacement with 27 ATS for severe TR. Now, I am a little concerned because had I were to make decisions probably for this unmarried girl, I would have given her all 3 tissue valves. If there was any concern about not giving tissue valves, I would have given 2 metallic valves on the left side and still continued to give her a bioprosthetic valve on the right side. But so be it. We are imaging people. We get patients of all the sorts all the time. And she is to have a family also. 11 months later, she presented in OPD with complaints of palpitation, shortness of breath on exertion. Of 15 days, by and large, everything was fine, except that the INR was low. It was 0.9. So clearly, she was not well anticoagulated. And this is what the pictures showed. So we could done an OPD, showed a normally functioning bileaflet mitral at, again, if you see, this is the place where you see both the leaflets. You see 2 blobs coming up. If, in case you are not seeing these 2 leaflets coming up into the LV side, be very concerned. If you look at this here, now because many a times you won't be able to see the leaflets as a disc. No, most of the times you don't. It's only these little things which keep bobbing up and down into the LV, which give us an idea that yes, it's a well-moving mitral prosthetic valve. So this is, mitral is functioning well. If you look at the gradients across aortic, the gradients are fairly good. The mitral gradients are also not too bad. The mean PG is 4, so I'm okay as far as the left side is concerned. Now my concern is of tricuspid valve. Now this is the problem when you implant a metallic valve on the tricuspid valve. There are 2-3 reasons why metallic valves should be avoided. One is that for a low pressure chamber, the thrombogenicity is so little that you don't need to put in a metallic valve. The degeneration of the right side of metallic valves is so little. And the problem is that the most common valve when you replace, which has a complete heart block needing permanent pacemaker, is tricuspid valve. You change the tricuspid valve, the chances are 40% that they would need a permanent pacemaker. And God forbid, if it is a metallic valve, then you are stuck, because then you are left with only one choice, that is the epicardial leads. So that is the reason why in right-sided tricuspid valve should be bioprosthetic regardless of what you do. This is what happened, not very good imaging in transthoracic, so we did turbulence across PHV, and mean PG across tricuspid valve was 11, grossly high. For a tricuspid valve, this is grossly high. Went on to do TEE, so mitral seems to be doing very well. When it comes to tricuspid, only 1 leaflet is moving, and that also very sluggishly. Again, go for more views, again, restricted movement, 1 is stuck, absolutely. PHV, there is gradient across tricuspid valves, high gradients, and fluoroscopy as what would show is stuck. If you look at this, this is the tricuspid leaflet valve, where it is, this is aortic, here is mitral, this is aortic, this is mitral, this is tricuspid, stuck. In fact, both are stuck. Very little movement of one is completely stuck. Fortunately, it is stuck in semi-open or semi-closed position, so that is the saving grace. Now, what to do? Expectedly, thrombolysis, because if you go by the guidelines, for left-sided stuck valves, the guidelines are fairly well clear that if you can do, you must do a redo surgery. For right-sided valves, you can do a thrombolysis. Now, thrombolysis was done with streptokinase. Again, that won't have been my first choice, but okay, we have data from streptokinase also, because that is the first thrombolytic agent which is used for stuck valves, and it has got a legacy. Done. Post-thrombolysis, this is what the movement are. Beautiful. Both of them are moving so beautifully well. So this is a serendipity that now post-thrombolysis, even with streptokinase, things are moving well. Turbulence across PHV is reduced, and mean PG reduced from 11 millimeters of mercury to. So this, I'm not going into the details of it, but right-sided prosthetic valves are not usually seen to be getting stuck, but here we are. I still have 5 minutes, so we can have some discussion, or I can show some more cases of stuck valve. Let me just go into more cases if I can show you some. Okay. This is again, this is a classical stuck valve which you come across. People would be thinking that we are a center who keeps getting stuck valve all the time. What do we do with our INRs? we are so poor at it. But it is that you see it all the time. Now, this is turbulence across. The first indication is gradients. There are very few times that you will commit the silent prosthetic valve thrombosis. But in case your gradients are high, be careful. You must start suspecting, and then you start seeing what is happening to the keeps getting stuck anyway. So if you look at this, the mean PG across the valve is 26, which is grossly high tachycardia. And again, beautifully shown pannus versus thrombus. It's like a lobster claw around the valve if you see that it is a pannus. I'm not going into the details. Somebody else has already talked about it. That's the reason I was avoiding this thing. Thank you very much, but for sake of remembrances, these are the kind of normal ranges which are to be remembered all the time. That if it is a bileaflet St. Jude's valve, roughly about 7 millimeters of mercury is the higher range. Star Edwards or caged ball and cage valve, you can accept gradients of about 10 millimeters of mercury. Tilting disc, about 7 or 8. Bioprosthetic, about 5 or 7. Best hemodynamics are with bioprosthetic. Thank you very much for a patient listening.
Thank you, Dr. Srivastava. Just wanted to ask, in the second case, that patient had LV dysfunction with the stuck mitral valve prosthetic.
First case?
The first case. So what was the day and what post-op date did she present?
No, she had a LV dysfunction to begin with also. Right. So it was not a new LV dysfunction. So suddenly what happened? Third day or fourth day it was. What is the cause? Pledget. Suture. Redo surgery.
If you are asked to provide a list of causes responsible for stuck valve thrombosis or something like that, which will be at the first leading causes?
Sorry, sir?
The leading causes that is responsible for stuck valves scenario.
Thrombus, sir.
Why did thrombus come from?
Thrombus.
Now, why not in all cases? Why thrombus? Do you need to have a...
Inadequate anticoagulation.
And about bioprosthesis?
So bioprosthesis, usually you don't get thrombosis. That is one big advantage. And in fact, if you look at the survival of people who have had metallic valve versus bioprosthetic valve, at the end of 15 years, the survival is exactly similar. Because bioprosthetic valves, they degenerate in 15 years, and most of the people who die of metallic prosthetic valve is because of inadequate anticoagulation or complications of BK. Correct me if I'm wrong, sir.
And
when these women, young women, were given bioprosthetic valve, I would always doubt it. I would say that's a wrong strategy. But over a period of years, I realized that mechanical valves have far more problems.
Far more problems.
Most of that data has come, fortunately, incidentally from All India Institute of Medical Sciences. Do you have any idea what is their report of prosthetic valve thrombosis? 6% per year. Adequately anticoagulated, well followed up. Ganesh Karthikeyan has published in American Heart Journal and JACC several times these reports. Some strange reasons. There could be many we could discuss, but the mechanical valve thrombosis is high, and then of course many of these people die. They go undergo thrombolysis. Death is even in thrombolysis described as much as
hemorrhagic strokes.
10-15%. So the
bleeds.
bioprosthetic valve is all right. Give it for 10, 15 years. Later on, we can do a valve in valve.
Valve in valve.
Valve
That's
in
a very
valve or
good
something
option.
of that kind. You can give and think of further. It is a tragedy that we have so much of rheumatic heart disease, and it's also a tragedy that their life is significantly shortened despite doing adequate surgery.
So another very interesting thing is that Realize study failed itself to use vitamin K, NOACs in only two conditions. One was moderately and severe mitral stenosis, and second was metallic prosthetic valve. So my take is that whenever given a chance, try to put in a prosthetic valve, even if it is atrial fibrillation, and put the patient on NOACs.
So we are going to see interesting data for Invictus study, where Ganesh Karthikeyan is presenting data of Rivaroxaban in mitral stenosis. I think he's presenting this ESC, if I'm not mistaken. Lead breaking trial. And I don't know what is the result, but if it could be a game changer. It could be a game changer. We wouldn't be imagining. The other thing which you have to understand, I keep repeatedly telling people, INR is a very imperfect test to tell you anticoagulation status. Why anticoagulation? Because anticoagulation, this only is a reflective of extrinsic pathway.
Only 2, 3, 7, 8 vitamin K dependent
extrinsic
factors.
pathway. And local factors of shear stress, roughening are not being counted at all. Because how much tissue factor you are releasing from those sutures, pledges, and the rings, and of course the roughening of the endocardium McCallum's patch, nobody knows. And you can't measure it by INR. So you have a good INR, but the patient still gets valve thrombosis. On the other, I mean, we have repeatedly seen INR of 6, 7, 8, the guy has a thrombosis. So we don't realize that this is a wrong way of, we don't have a perfect system. There is a way actually of doing something, this is something thrombin elastography. That's the way to find out exactly how anticoagulation patients are, but that's not practical. This is one area which, of course, in ECHO meeting, sometime we should discuss about prosthetic valve in greater detail, but thank you for bringing us in notice. I think this is one area where we have to discuss this issue. Why, despite adequate anticoagulation, so much of valve thrombosis occurs? Because the INR is an imperfect test for these patients.
Is there any difference between speaker?
Even if you maintain round the clock, INR is a test of extrinsic pathway. And,
So,
and it
just
doesn't tell you if the local factors dominate in a prosthetic valve.
No.
Local factors are not being told by
To
INR.
both of you and speaker, is there any difference in the incidence of valve thrombosis between aortic valve and mitral valve?
Absolutely.
If it is so, why?
3-to-1 ratio.
Why?
High flow. High flow washes
So
out.
that is very important. But this high flow phenomenon explaining the difference between aortic and mitral valve is not applicable on the right side.
To right side, still low flow is there.
Yeah.
That is why there is a more thrombosis there.
It is more thrombogenic, sir.
More thrombogenic.
That is the reason why-
tricuspid are more thrombogenic. In fact, tricuspid valve, as much as possible, just do repair. Don't put a valve. If you have to put a valve, put a tissue valve.
Correct.
And the mechanical valve should be our last choice. But unfortunately, it is much easier to put a mechanical valve. And there are commercial reasons also. Don't
Cheaper.
forget that.
It is cheaper.
No, don't forget the commercial reasons of putting prosthetic valve, the metallic prosthetic valve on the right side, which nobody talks of. The newer bioprosthetic valves?
Bioprosthetic. So they claim 15 years, 20 years.
From surgical aspect, one thing I want to highlight, that bioprosthetic valves I have used in my career, usually over the age of 60 or at least 55. And in some cases, of course, I have used bioprosthetic valve in the young female of childbearing age. But thinking that in the mortality in the bypass, open heart surgery has come down to such a zero level that we have used in the young adult of young lady of childbearing age. But regarding the decaying process is more common in bioprosthetic valve. But as the fixation process is increased, this decaying level is also diminished, and bioprosthetic valves like Perimount I have used is more than 25 years experience in Perimount valve. So usually the stuck valve is common in the prosthetic valve, particularly of course in the mitral region, and echocardiographer greatly helps us to say whether any streptokinase infusion will help in the relieving of the stuck or not. And when such does not occur, they usually refer us to us. Usually we all use the rotating valves, and after the opening of the left atrial particle in the mitral side, where the stuck is common, we usually rotate the valve, and usually we find the free movements of the bile blades. Usually stuck is removed. And by this way, the early intervention, of course, is needed for the sake of life.
Thank you. But you are right that the Epic Supra and Perimount Magna valves are actually much better valves. They are lasting longer. And the supraannular location, positioning of the aortic valve certainly is helping us to get better effective orifice area. And better effective orifice area surprisingly results in lower degeneration rates. So we have multiple things which we are looking at, but the need of the hour is to make still better tissue valves.
Yeah.
We want to get rid of the prosthetic.
We have another speaker to talk on this issue.
Our next speaker is Dr. Paramarth Bhattacharya, who will speak on late post-op echo.
And we must know what is the word late stand for.